Good evening to you all. Thank you all for your presence in the last meeting. So I take this opportunity to thank the Rajagiri Medical Department for presenting a wonderful case. Today we have got 3 cases from the Department of Medicine, Medical College Hospital, Kolenchery. I invite Dr. Abraham Ittyachen and Dr. George Koshi to the dais. Please come. Dr. Abraham Ittyachen needs no introduction. He is the professor and head of the Department of Medicine, Kolenchery Medical College. Dr. George Koshi is an associate professor, Medical College Hospital, Kolenchery. Thank you.
Thank you, sir, for that introduction. I understand for this meeting of ours, we are only discussing cases. Now, all of us practice in different settings, and most of the time, the cases that we see are actually straightforward cases. They say that when you see a patient, either your thought process goes in one line, in one direction, or in some rare instances, you should have a parallel thinking also. You should think parallel also. In fact, some of the cases which we are going to present here actually are of that type. It involves thinking in 2 or 3 directions, totally atypical. So I'm sure that most of the senior physicians would have seen such cases in their lifetime, in their experience. And for the upcoming generation also, it would be a valuable lesson, because a case need not always behave like what we read, study in well-established textbooks of medicine. Sometimes it's totally different. And like they say, sometimes experience is the best teacher. So I hope this cases which our PGs are going to present will be useful for all of us, and there will be a take-home message. Now I would like to invite my colleague, Dr. George Koshi, to say a few words.
Yeah, we'd like to thank the API for giving us this opportunity to speak and present our cases. We have 3 unusual and slightly challenging cases to present. That's why we said a trilogy of challenging cases from MOSC. So we will start the presentation if there is no other formalities.
The first case will be presented by Dr. Ancy. She's the final year PG resident.
Good evening, one and all, respected seniors and dear friends. Today I am going to present an atypical case of infective endocarditis. I would like to take the discussion under these headings: introduction, the case report, discussion, conclusion, and the references. Infective endocarditis is a well-known clinical entity, and the clinical heterogeneity of infective endocarditis can prevent rapid recognition, early diagnosis, and timely treatment, which are essential to reduce the morbidity and mortality associated with this disease. Here we report a case of 49-year-old male admitted with acute exacerbation of COPD with type 2 respiratory failure, which was eventually also diagnosed to have infective endocarditis involving the mitral valve. Our patient is a 49-year-old man who is a painter by occupation and a chronic smoker. He is a known case of COPD. He has a past history of all pulmonary TB, and recently he had a COVID-19 infection. He presented with complaints of generalized tiredness and breathlessness of 5 days duration. He also gives a history suggestive of paroxysmal nocturnal dyspnea, and post-COVID, he also had dyspnea on exertion. On examination in the emergency room, patient was initially conscious and later he became drowsy. His JVP was raised. He was having a pulse rate of 98 per minute regular, and his BP was 150 over 100 millimeters of mercury in the supine position. His respiratory rate was 16 per minute initially, and he was febrile. His saturation was only 86% in the room air, and we started him on non-invasive ventilation. Arterial blood gas analysis in the emergency room showed pH of 6.9, PCO2 of 75, PO2 of 82, lactates 6.2, and bicarb of 15. And in view of worsening desaturation and poor GCS, he was intubated. Post-intubation, his saturation improved. On examination, chest, we had bilateral basal crepitations, and CVS examination JVP was traced. There were no murmurs. Other systems were unremarkable. And in the ER, he developed a SVT, and which was cardioverted. And this was the first X-ray taken. It's an AP erect view. It is showing an apparent cardiomegaly with bilateral pulmonary infiltrates. And a provisional diagnosis of COPD with type 2 respiratory failure, heart failure, and status post COVID-19 infection was made, and he was admitted to our ICU. These were his investigations. On the day 1, there is we can see total counts were elevated, and all other investigations were within normal limits. And coming to other investigations, his ProBNP levels were elevated. He had serial elevation of tropi levels. His CRP was elevated. And we also sent ET secretion AFB twice, and it came out to be negative. And pneumocystic pneumonia staining was done in the ET secretion, that also was negative. His lepto-IgM levels were sent, that was negative. And his blood picture showed just neutrophilic leukocytosis. And all other tests were within normal limits. And after sending appropriate specimens for culture, blood culture and endocarditis secretion cultures were sent, and he was started on intravenous antibiotics, levofloxacin, and piperacillin and tazobactam. And he was managed with IV diuretics, steroids, and other supportive measures. And cause in the hospital, once the acute emergency had settled, a detailed clinical examination was done, and on general examination, he had poor oral hygiene with dental plaque and caries. And on auscultation, there was a systolic murmur which was heard in the mitral area radiating to the axilla. And the same day, a bedside echo was ordered, and it showed adequate LV systolic function, flail mitral valve, and moderate to severe MR, and LA and LV was dilated. On day 2, patient had hypercalemia, metabolic acidosis, and mild elevation of creatinine. It was managed with anti-hyperkalemic measures and bicarbonate infusion. And on the same day, patient developed AF, which was rewarded with amiodarone infusion, and a cardiology review was taken. And on day 4, patient was extubated, and he was put on non-invasive ventilation, and later he was maintaining saturation on 6 liters O2. This was the X-ray on the day 4. Next, on day 6, a formal echo was ordered, and also the blood culture reports came, which was sent on the first day, came on the day 6. And you can see the blood culture sent on the day 1 revealed Streptococcus parasanguinus, and it was sensitive to ampicillin, cefotaxime, cetirizine, and penicillin. So the first blood culture was sent on the day of admission, and after 36 hours of incubation of this culture, this material in the Bactec machine, it showed a growth, and the gram smear was done. It showed a gram-positive cocci in short and long chains. And later, it was subcultured in blood agar, chocolate agar, and Makongi agar. It was kept for further incubation, but there were no growth. And subculturing was done, and a microaerophilic medium was given, and subculturing was also done in thioglycolate growth. So on day 5, the original blood agar plate showed some pinpoint colonies, and even the microphilic medium, blood agar, and thioglycolate growth also showed same pinpoint colonies. Biochemical test, the bile esculin test was negative, and the final identification of the organism was done after 31 hours of incubation of this subculture in the Vitec 2 machine. It was actually reported after 6 days. And the formal echo done on the day 6 showed a flail mitral valve. There was AML flail into left atrium. We can see in the parasternal long axis view, we can see 0.6 into 0.3 centimeter echogenic structure seen attached to the AML, anterior mitral leaflet, and it was supposed to be vegetation, and there was dilated left atrium and left ventricle, and there was severe PAH. And a diagnosis of infective endocarditis was made, and he was added on intravenous ceftriaxone. A cardiology review was taken, and he was advised to have an early mitral valve replacement in view of refractory heart failure. And repeat blood cultures done were also steroid. So as the patient's relations decided to undergo mitral valve replacement in another hospital, he was referred to another center. So a final diagnosis was infective endocarditis, severe mitral regurgitation in heart failure, acute exacerbation of COPD in type 2 respiratory failure, impaired glucose tolerance, dyslipidemia, and status post COVID-19 infection. So we followed with the patient in that hospital. He underwent a mitral valve replacement after 2 weeks of triple antibiotic therapy. And prior to surgery, he had teeth extraction as he had much of dental plaque and caries. and post-operative period was uneventful except for few episodes of fever. However, his mitral valve swab culture was negative, and he had taken a complete course of 6 weeks of antibiotics, and currently he is convalescing at home and is on oral anticoagulation. So this was the echo done after the valve replacement. Next, just as a few topics I would like to discuss about the infective endocarditis. Due to lack of time, we'll discuss some of the topics. So this is the person, Lasser Rivere. He is the first person who described infective endocarditis. He was the one who described about a patient presenting with palpitations and irregular pulse who died after a relatively short course of therapy. And at autopsy, round carbuncles were found in the left ventricle. It was resembling a cluster of hazelnuts filling up the opening of aorta. Probably the patient presented with atrial fibrillation, and he had a aortic regurgitation. And this was the earliest description of infective endocarditis in the history. Later, in 1885, William Osler, he's a Canadian physician. He's one of the fathers of clinical medicine. He's the one who gave the most accurate description of infective endocarditis. So he described this in his Gulstonian lectures in 1885. It was a series of infective endocarditis lectures which described the infective endocarditis in soldiers who got injured in the war. Then about the etiology, here the patient factors: age more than 60 years, male patient, and intravenous drug use. In our patient, he was a male patient and he had poor dental hygiene, and it increases risk. And the other cardiac factors like history of prior infective endocarditis, prosthetic heart valve, or other cardiac devices also contributed to the formation of occurrence of infective endocarditis. And here our patient had mitral valve prolapse, and that might have had contributed. Next, about the most common organisms causing major clinical forms of infective endocarditis. Actually, it is divided into native valve, prosthetic valve, endocarditis, and injection drug users. And the most common organism is Staph aureus in healthcare associated. In case of community occurred, it is streptococci. And about the pathogenesis, here we got a virulent streptococci. They are more prevalent in the oral cavity, of which parasanguinus is present on the dental plaque. And fibronectin, a complex glycoprotein found on the surface of the oral epithelial cells, promotes the attachment of gram-positive cocci. And the fibronectin secreted by the endothelial cells, the platelets, and the fibroblast in response to vascular injury is one possible molecule that mediates the adherence of streptococci to the heart valves. And it has got an insidious onset followed by a subacute but progressive course. And most patients' symptoms develop within 2 weeks of presumed onset. And often it is 5 weeks from the time of initial symptoms. Then about the major clinical features, you can see fever, chills and sweats, then heart murmur, and new regurgitant murmur. And these are the other peripheral manifestations. You can see rod spots, splinter hemorrhages, petechial hemorrhages, osseous nodes, and J&V lesions. Next, about the modified Duke's criteria. As we all know, there is major criteria and minor criteria. First one is positive blood culture. Second is evidence of endocardial involvement in the echocardiogram. And the minor criteria: predisposing heart condition, microbiological evidence not supporting the major criteria, then fever, vascular phenomenon, and immunological phenomena. Then the pathological criteria is positive histology or microbiology of the pathological material. And we tell if there is a definite infective endocarditis is diagnosed if there is one pathological criteria that is positive, or a 2 major criteria, or 1 major and 3 minor, or a 5 minor criteria. So possible infective endocarditis is 1 major and 1 minor criteria, or a 3 minor criteria. Next, about the management in short. So choice of antibiotic depends on the following factors like native valve, prosthetic valve, or the people who inject drugs. So according to the organism, there will be difference in the management. So penicillin susceptible organisms, we'll give, if streptococci, we give ceftriaxone, penicillin G, or vancomycin. Then in case of enterococci, we give ampicillin, penicillin G, or vancomycin. So coming to Staph aureus, we can give cefazolin, nafcillin, or vancomycin. Then here is a group of organisms, we usually give ceftriaxone, ampicillin, sulbactam. In case of Coxiella, doxycycline. Then about the surgery. Here our patient underwent a mitral valve replacement, and the surgery, early surgical intervention is prior to finishing the antibiotic therapy is indicated if the following complications arise. Like there is associated valvular regurgitation or dysfunction, heart failure, intracardiac abscess, or a persistent infection and a difficult to treat organism. Next, concluding, see our patient's case was unique as he was young, post-COVID, and he had a negative valve infective endocarditis, and he presented with type 2 respiratory failure and not the typical manifestations of infective endocarditis. He had a refractory heart failure requiring early valve replacement. And his blood culture grew Streptococcus parasanguinus. It is one of the rare cause of infective endocarditis among the viridans group. And it is also seen in the oral cavity. And men more than 45 years of age who have mitral valve prolapse are at an increased risk for infective endocarditis. And infective endocarditis in the setting of post-COVID has been reported recently. These are some articles which I found useful. This is a clinical profile of infective endocarditis patients with recent COVID-19 infection was published in American Journal of Medical Sciences. This was a systematic review, and it all published case of 340 cases of definite and probable infective endocarditis cases were reviewed. And in this, respiratory complaints were more common presentation, and the time interval was days to weeks. And our patient, he presented after 6 weeks of COVID-19 infection. And the pathogenesis remain undefined. However, it is postulated that damaged vascular endothelial surfaces can be impacted by endothelitis, and this same holds true for valvular endothelium also. And this another article which was published in Chest Journal. This is about a respiratory failure in acute infective endocarditis cases, the trends and outcomes in the data of 15 years data. And in this, respiratory failure was identified as an underappreciated complication of infective endocarditis, and it showed physicians to be vigilant to respiratory failure as a complication of this disease, as it carries significant morbidity and mortality. So the take-home message is, this case highlights the importance of yet another risk factor for infective endocarditis, that is post-COVID setting, an atypical presentation of infective endocarditis, and the rare organism within the viridans family, that is Streptococcus parasanguinus, and the importance of the oral hygiene, and repeated clinical evaluation of the patient, and an open mind to modify the diagnosis accordingly. These are the references which I found useful. Okay. Thank you.
Why we call this atypical, it's probably you realize that they didn't have any of the typical presentations of infective endocarditis. Actually, patient came with type 2 respiratory failure. Now, there are some clinical cases or cases which we see where we see the investigation and then go back to the examination. This was one of those cases. Initially, it was not possible to do a proper clinical examination because the patient came in with respiratory failure. He had to be put on the ventilator. So later, when the patient actually improved, only we did a good clinical examination, we picked up this murmur. But even at that point, we probably thought that it was not related. But when the blood culture grew Streptococcus, its doubts started appearing. Why did that grow? Then again, we went back to the patient and slowly we picked up the vegetation. And even if you look at that vegetation, it doesn't satisfy all the criteria for infective endocarditis. So this is why I told you in the beginning, sometimes there are some things which do not go as what is given in the textbooks. So this was one such case. So because of the cardiac failure that was not responding to the treatment, a cardiologist also suggested that this patient should undergo valve replacement, and he is doing very well. And of course, the two things which he mentioned, that is post-COVID, which is actually now considered as a risk factor for infective endocarditis, the Streptococcus parasanguinus, and infective endocarditis presenting as type 2 respiratory failure. And incidentally, actually, she got the best paper presentation in the recently conducted state conference at Kumaragam. She had presented this case. Okay, now we can have the next case. Dr. Anju. She's a first year PG resident. Anju Sajeev.
Presenting the case of 31-year-old female from Kodamagalam, referred from the local hospital in Kodamagalam. Her symptoms started with history of low-grade intermittent fever 1 month back. It was associated with a low backache, bilateral lower limb pain. She also had dull aching diffuse abdominal pain, which was treated as leptospirosis from outside hospital 1 week after the onset of symptoms, and symptoms subsided with medications. Few days after discharge, she again had low-grade intermittent fever, more towards night, and not getting relieved with antipyretics. She had severe low backache at rest and increased on lifting leg off the bed and had difficulty in walking due to intense pain which increased towards night. It was associated with non-bilious, non-projectile vomiting, and she was given analgesics from multiple local hospitals for the pain before she was admitted in MOSC Medical College, Kolenchery. On examination, she was conscious, oriented, no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no edema. Pulse rate was 83 per minute, regular in rhythm. BP was 114/70 millimeter mercury, right arm in sitting position. Respiratory rate 20 per minute, thoraco-abdominal. SpO2 was 99% room air. Per-abdomen soft, diffuse abdominal tenderness present, no gauding, no rigidity, bowel sounds present. Cardiovascular system, S1/S2 normal, no murmur. Respiratory system, normal vesicular birth sounds, air entry bilaterally equal. Nervous system examination, higher mental functions normal, cranial nerves within normal limits. Motor system, upper limb and lower limb grade 5 power. Movements of lower limb restricted due to pain. Deep tendon reflexes normal, bilateral plantar flexor, spine tenderness present over L1 to L4 region. This was the dorsal spine X-ray, which shows some lytic lesions. This was the lytic lesions. And this is the LS spine X-ray, which also showed some lytic lesions. This was the lytic lesions. This is a chest X-ray which showed normal study. UST abdomen done which showed markedly enlarged and heteroechoic bilateral ovaries with markedly increased vascularity. Bilateral kidneys with grade 1 to 2 renal parenchymal changes. Bulky left kidney, mild hepatomegaly with a grade 1 fatty change, mildly dilated CVD. Gynecological consultation done in view of abdominal pain and bilateral bulky ovaries, and pervaginal examination done which showed adnexal tenderness present, cervical motion tenderness present. Their impression was choriophoritis or pelvic inflammatory disease. Our DDs was the first one, pelvic inflammatory disease, because the patient have severe abdominal pain and UST abdomen showed bilateral bulky ovaries, and pervaginal examination showed cervical adnexal tenderness present. And the second DD was psoas abscess, because the patient have low backache, intense pain, and pain was increased on lifting leg off the bed. And the third was extrapulmonary TB because of the long history of fever, lytic lesions of the bone, choriopod spine. The investigation done showed HB 10.8, PCV 31, total count was 13,500, polymorph 75, lymphocyte 15, ESR 120, platelets 2,29,000, serum sodium 140, serum potassium 3.1, serum blood urea 88, serum creatinine 2.1, RBS 79, total bilirubin 1.8, direct bilirubin 0.8, SGOT 107, SGPT 76, and ALP 500, total protein 7.1, albumin 3.5, globulin 3.6, serum amylase 70, serum lipase 112. Urine routine showed 4 to 6 WBCs. Then we did a serum calcium which was 17.3, and serum uric acid 5.7, serum phosphorus 5, serum magnesium 1.6. So immediate therapy was directed at restoring the intravascular volume and promote calcium excretion with the infusion of 0.9% saline, given adequate hydration, and repeated calcium in the evening was more than 40. Then we did a plain CT abdomen which showed bilateral bulky kidneys, left more than right, multiple lytic lesion noted in the visualized bone of spine and pelvis, mild hepatomegaly, left renal calculus, bilateral bulky ovaries. Then this is a patient with a 31-year-old female with high ALP, hypercalcemia, and elevated ESR with spinal tenderness, choreolytic lesions. Our DDs was disseminated TB, multiple myeloma, sarcoidosis, hyperparathyroidism, and malignancy with bone mets. Rule out in each cause. Before that, we did a nephrology consultation view of AKA hypercalcemia and for fitness for contrast radio imaging. One session of hemodialysis taken through right femoral catheter in view of hypercalcemia, and the next session of HD taken after contrast imaging. Injection zoledronic acid was given after 2 sessions of HD after creatine had come down. Rule outing each course, we did a serum electrophoresis which showed no M band. ANA screen was negative, urine AFP negative, peripheral smear showed normocytic normochromic RBC with predominant neutrophils. Then we did an MRI whole spine screening which showed entire visualized axial skeleton showed altered Myra signal intensity with a multifocal STIR hypertendence lesion. These lesions show patchy heterogeneous post-contrast enhancement, no associated soft tissue mass, no bone expansion, no collapse is noted. Few of the sacral and iliac lesions show rim enhancement with no central, no enhancing area. C4, C5, C6 intervertebral disc shows desiccation changes with mild diffuse bulge, producing ventral thecal sac indentation, no nerve root compression. Enlarged right paratracheal, cervical nodes, hepatosplenomegaly and bilateral ovarian lesions. Their impression was a disseminated skeletal lesion with early degenerative disc disease as described, and the imaging differential diagnosis was disseminated tuberculosis, histiocytosis lymphoma spectrum and disseminated metastasis. Then we did a PTH which was 11.4 which was low, 25 hydroxy vitamin D 57.2 and TSH 1.5. This is a flow chart given in Harrison for evaluation of patient with hypercalcemia. This patient is a hypercalcemia acute duration with PTH low. So consider malignancy. We did malignancy workup. CA was 32.8, CA 125, 214, CA 99 less than 2, which was inconclusive. Then oncology consultation done and advised FNAC lymph node plus bone marrow aspiration plus biopsy, and FNAC and bone marrow biopsy done under aseptic precautions. And MRI abdomen pelvis plain and contrast done, and second session of HD done after MRI contrast of abdomen and pelvis. This was the report of MRI abdomen and pelvis plain contrast. Both ovaries are bulky, right 5.6 into 2.9 centimeter, left ovary 6.4 into 3.5 centimeter, features suggestive of bilateral ovarian mass, possibility of metastatic deposit or primary ovarian neoplasm. Possibility of inflammatory mass like TB cannot be ruled out. Entire visualized axial skeleton shows altered marrow signal intensity with multifocal STIR hypertendence lesion. Possibility of Cori disseminated TB or metastasis. Then we did a CECT thorax which showed a small well-defined lesion noted in the anterior segment of right upper lobe. It is closely abutting the horizontal fissure in its inferior aspect. And the morphological characters are, it measures 10.9 into 10.9, 14.5 into 12.5 millimeter, heterogeneous enhancement seen, have spiculated margins with pleural tailing, few tiny non-enhancing lesions seen within Cori necrosis, no calcification, no air fluid levels within. Dense airspace opacity with a prominent air bronchogram noted on the posterior basal and medial basal segment of bilateral lower lobes, likely consolidation. And there are multiple enlarged bilateral cervical, supraclavicular, mediastinal lymph nodes seen involving the prevascular, subaortic, right upper, right lower, paratracheal, right hilar and subcarinal regions, largest in the right upper paratracheal regions. Multiple lytic lesions noted in the visualized TL vertebral bodies and the posterior elements of few of them. Similar lesions seen in the left acromion, glioid and sternal regions. This was the impression, a heterogeneously enhancing soft tissue density mass lesion in the anterior segment of right upper lobe with characteristics and cervical, supraclavicular, mediastinal lymph nodes as described. Likely neoplastic etiology, likely malignant lesion. Lytic lesions in the visualized bone as described, likely metastatic deposits. Dense airspace opacities with a prominent air bronchogram noted in the posterobasal and medial basal of bilateral lower lobes, likely consolidations. Then our investigated FNAC report arrived as atypical cluster, cell cluster suspicious of malignancy. Bone marrow biopsy impression was metastatic adenocarcinoma. When they did a immunohistochemistry, morphology and immunohistochemistry are in favor of metastatic adenocarcinoma from a primary in lung. She has an MRI brain as advised by our oncologist to rule out a brain metastasis. And MRI brain was negative for brain mets and showed increased intake in clivus and calvarium. Patient continued treatment at Ernakulam GH under oncology due to financial constraints. Our final diagnosis is hypercalcemia secondary to malignancy, primary adenocarcinoma in the lung, multiple disseminated metastasis in the bone, bone marrow and lymph nodes. Thank you.
Thank you, Anju, for that excellent presentation. This was a very puzzling case, and we were struggling for it over the case for about 10-12 days. She is a 31-year-old lady who came to the casualty with severe pain, bone pain, and she had this history of fever. And she had so much of tenderness. When we did this, when we were touching her, feeling her, she had pain, and the SLRT was very strongly positive. And in casualty, first, because they did the ultrasound, they found this bilateral ovarian enlargement. First they called gynec, and then gynec did not admit, saying she had fever. So then she was admitted under us. Then we did this workup, and very unusually we found this very high calcium. And then when we did a review of the X-rays, we found there were multiple lytic lesions. And as workup for calcium, we did the other workup. We did PTH, we did alkaline phosphatase. Alkaline phosphatase is elevated, but PTH was unusually low. That set our mind thinking in another way. Then our next priority was to bring the calcium down. So first we gave IV fluid. We gave 4 pints of saline, and we gave Lasix. And we gave 1 shot of dexamethasone, which with the calcium came down, but it was still more than 14. So when it is more than 14, I remember I got quite alarmed, and I rang up Anju and told her, please call nephro to review again, because if it is more than 14, she may need to be dialyzed. So they did 1 session of hemodialysis. In the meanwhile, simultaneously, we were doing a workup to look for a possible cause. So we did this MRI. MRI again showed this bilateral bulky kidneys and this bulky ovary. That ovary actually made our mind think in another way, because we don't know if it is some primary coming from the ovary. But even the MRI showed multiple lytic lesions in all the bones in the axial skeleton. Then we went ahead. They said MRI itself won't show. By the time before we did the MRI, as per advice from our nephrologist, he did 1 more session of dialysis so that they could give the contrast for the MRI. And by the time the creatinine had come down, so we confidently gave that 1 dose of zoledonic acid to bring down the calcium, after which calcium was showing a downward trend. Then we did, they said you do a CECT also, because MRI won't visualize the other organs. So then the CECT showed this lesion in the lung. And there were these multiple lymph nodes. So we went ahead with this ultrasound guided FNAC of the lymph node, which showed atypical cells. And because there was this extensive bone marrow infiltration, even the oncologist, Dr. Sini, she said, why don't you try and do a bone marrow biopsy? Actually, the bone marrow biopsy is very difficult. We could not get any aspirate because, and you can just go to that bone marrow biopsy report. It is a solidly cellular bone marrow, so nothing came in the needle. So after a lot of struggle, we got 1 piece. 2-3 times we tried to aspirate, we got 1 piece. She was already in a lot of pain. We had to put her in the left lateral position. And with that piece, they got this imprint which showed solid bone marrow, complete replacement by cuboidal cells, and they are arranged in an adeno pattern, and numerous tumor giant cells and atypical mitosis. That's when we realized that we are dealing with something that is metastatic carcinoma. And then we got the report of the CT which showed the lung lesion, and then we did adenohistochemistry on this that helped to clinch the diagnosis. We were happy we could get the diagnosis, but it was actually very tragic. 31-year-old lady moving about with this. When we asked the mother again, she said she had been having bone pain for more than a year. But people will disregard pain. They will go to a local practitioner. They will try some medicine. They will try multiple local application, because you don't expect such a sinister diagnosis to be hiding there like that. And she has a 7-year-old son. Finally, they took her to oncology at Ernakulam General Hospital, and they started chemo there. And I spoke to Dr. Balanumari once just to find out how she was. In the beginning, she had thrombocytopenia. She had to be stabilized from that, and then they gave her this platinum-based agents to treat her. So we were happy we got a diagnosis. The only thing, it was a very tragic diagnosis. Yeah, it's an unusual case and very challenging case. That's why I thought you'll present. We'll have the third presentation from Dr. Nanditha. It's an unusual case of paraplegia.
Good evening all. First of all, I would like to thank my teachers, Dr. Abraham sir and Dr. George Koshi sir, and API and IMA for providing me this opportunity to present this case. Here I present a case of a 38-year-old male who is a native of Bihar with a recent history of travel to Orissa 1 week prior. He presented with complaints of fever and headache since 2 days and urinary retention since 1 day. In the ER, he was catheterized for urinary retention and he was advised admission, but as the bystanders were not willing, he was discharged against medical advice. Past history. He has no other known comorbidities, no history of any recent vaccination, no history of intravenous drug abuse. Family history, there is no significant family history. Personal history, he consumes a non-vegetarian diet, but he has a history of use of alcohol, tobacco and cannabis. The next day, he again presented to a casualty with complaints of urinary retention, and this time there was a history suggestive of an episode of generalized tonic-clonic seizure lasting around 4 minutes. So in initial examination, he was conscious, oriented, moderately built and nourished, no pallor, icterus, clubbing, cyanosis, lymphadenopathy or pedal edema. There were no neurocutaneous markers, no signs of any nutritional deficiency, no rash and no eschar. His vitals, he had a pulse rate of 67 per minute, regular, normal volume and character, no radiofemoral delay, all peripheral pulses were palpable. He had a blood pressure of 150/90 millimeter mercury in right arm in supine position. His respiratory rate was 16 per minute, abdominothoracic, and his saturation was 97% in room air. Initial examination of central nervous system, he was conscious and oriented, higher mental functions were normal, cranial nerve examination, motor system, sensory were unremarkable. Skull and spine normal, there was no peripheral nerve thickening and no signs of meningeal irritation. Chest, air entry bilaterally equal and normal vesicular breath sounds were heard. Examination of cardiovascular system, first and second heart sound were heard normally, there were no added sounds. Per abdominal examination, soft, non-tender, no guarding or rigidity, no agenomegaly and bowel sounds were heard. Initial investigations were also within normal limits. Then he was admitted. Next day, the patient developed altered sensorium, and this time he developed weakness of his right lower limb. On examination, cranial nerves normal. The right lower limb had a power of grade 3 out of 5. It was hypertonic and the deep tendon reflexes were diminished. The left lower limb had normal power, tone and reflexes. Upper limbs also had normal power, tone and reflexes. Sensory system and cerebral function within normal limit. Plantar was bilaterally mute. So he had an impression of a myelopathy above L1. Then the next day, he developed weakness of both his lower limbs. He was conscious and obeying commands. Pupils were equally reactive to light, extraocular movements full and other cranial nerve examination within normal limits. His upper limbs had normal power, grade, tone and reflexes were preserved, but this time both his lower limbs now had a grade power grade 1 out of 5 and it was hypertonic and there was diminished deep tendon reflexes. Now he had a clear sensory level with a decreased sensation below the umbilicus. Abdominal reflex was absent and plantar was bilateral mute. So now the impression of myelopathy above D10 level. Next day, his sensorium deteriorated. The patient was now drowsy and disoriented. The weakness progressed to involve both his upper and lower limbs, but pupils were equally reactive to light. Extraocular movements full, cranial nerve normal. Now his power grade 1 out of 5 for bilateral lower limbs and a grade 3 out of 5 power for bilateral upper limbs. He had hypotonia and diminished deep tendon reflexes in both his upper and lower limbs. Now he also developed diminished respiratory movements. Plantar reflex was mute. The patient started desaturating, so he had to be intubated and put on mechanical ventilator. Day 6, the patient is continuing on ventilator support. His GCS was even VT-M1 and he had hypertonia and diminished deep tendon reflexes of all the 4 limbs. Now on a chest x-ray, he developed aspiration pneumonia, left-sided infiltrates in the mid and lower zone. Day 7, he is continuing on ventilator support. There is not much improvement. By day 8, he developed hypertension and he had to be put on inotropic support. Pupils were equal and reactive to light. The upper limb, he developed myoclonic movements of his upper limb, but hypotonia and diminished deep tendon reflex of both upper and lower limbs. Plantar reflex was mute. By day 9, patient is on ventilator and inotropic support. Now the pupils became sluggishly reactive to light, and there was hypotonia and diminished deepening reflexes of all 4 limbs. He also developed reduced urine output. His ABG showed metabolic acidosis, and now his platelet had also started falling. His creatinine levels had rise. He had developed an acute kidney injury. Day 10, patient is continuing on ventilator support. There is not much improvement. By day 11 also there is not much improvement, but his platelets have further fall. He has developed sepsis and acute kidney injury. By day 12, the patient is continuing on ventilator support, but he now developed one episode of generalized tonic-clonic seizure. His pupils dilated with congenital chemosis. Extraocular movements were restricted, and now he had myoclonic jerks. And chest X-ray showed bilateral infiltrates and increase in the heterogeneous opacity in right and left, mid and lower zones. He further developed worsening of metabolic acidosis. By day 13, the patient developed bradycardia and hypotension, and unfortunately we lost the patient to his illness despite resuscitative efforts. Just to summarize, a 38-year-old young male who is a native of Bihar presented with a short febrile illness with generalized tonic-clonic seizures and early bladder involvement. Subsequently, he developed ascending paralysis, initially involving the right lower limb, then the left lower limb with a sensory level at the umbilicus, then bilateral upper limbs over a span of 5 days, which then progressed to respiratory paralysis, which was supported on mechanical ventilation. At the same time, his sensorium also deteriorated. He developed bilateral pneumonia, later which progressed to sepsis and acute kidney injury and severe metabolic acidosis. Ultimately, he succumbed to his illness. These were his investigations. Initially, all the investigations were normal, but progressively he developed acute kidney injury, and further he developed sepsis with falling platelets, elevated total counts. His ABGs initially, by day 5, by the time he developed respiratory paralysis, he had a type 2 respiratory failure, and he had to be put on ventilator. Later, he had worsening of his renal status and progressed to metabolic acidosis. So this was his workup. His blood and urine culture was sterile. We did a dengue workup, which was negative. Because of his location from Bihar, we did a malarial parasite, which was not seen. Vidal was negative. Lepto-IgM was borderline positive. And scrub typhus IgM was negative. All viral markers were negative: HBsAg, anti-HCV, and HIV ELISA. We did anti-myelin oligodendrocyte glycoprotein antibody, which was negative. Anti-NMO, anti-neuromyelitis optica antibody, which was also negative. Serum ACE levels were normal because we suspected sarcoidosis. ANA screening was negative. This was a CSS study. He had elevated proteins. Sugar was normal. Total cells were 50, and which was lymphocyte predominant. ADA was 39. And we did a gene expert MTV of the CSF, and MTV was not detected. Gram staining, no organism seen. His COVID RT-PCR was negative, and we did a peripheral smear, which is normocytic, normochromic with blood picture with neutrophilia. CRP was elevated. ET secretions due to the pneumonia, there was gram positive and gram negative bacilli seen. Radiological investigation. Initially, his CT brain showed no significant intracranial abnormality, and by the time his sensorium deteriorated, we did an EEG, which showed abnormal recording demonstrating diffuse generalized slowing with no epileptiform spikes. Echo was normal, no regional wall motion abnormality, fair LV systolic function with mild MR, no pH, no clots or vegetation. This was his MRI brain screening, which showed subtle leptomeningeal enhancement in the interpeduncular cistern and along the ventral surface of the medulla. There was a long segment T2 hyperintensity involving the distal thoracic spinal cord, extending from D4 level involving the conus. So the initial MRI shows a. And once he developed respiratory paralysis, we did a follow-up MRI, which showed progression of the spinal abnormality into the cervical cord with extension into the cervicomedullary junction, and T2 flare hypointensitics were also noted in the subcortical white matter of bilateral posterior frontal location, which was a new development. This was the second follow-up MRI. So a final diagnosis was acute encephalomyelitis with longitudinally extending transverse myelitis, probably infectious, with aspiration pneumonia, sepsis with acute kidney injury. So initially he was started on empirical antibiotic therapy for meningitis with ceftriaxone, vancomycin and acyclovir. Later we also started him on doxycycline. He was started on IV methyl prednisolone by day 3, but he did not show much improvement. So we started him on plasmapheresis by day 5. 2 sessions were done, but then it had to be withheld due to hypotension and electrolyte imbalance. So as a next therapy, we started him on IVIG infusion, but that also patient did not show much improvement. He was managed with anti-epileptics, levetiracetam, phosphonatoin, and finally we had to do hemodialysis in view of the deranged RFT and severe metabolic acidosis. So review of transverse myelitis. So transverse myelitis, there are different causes. Para-infections is most common. Viral, which can be herpes simplex, herpes zoster virus, cytomegalovirus, Epstein-Barr virus, and enterovirus. AIDS. Bacterial causes include mycoplasma pneumonia, Lyme's borreliosis, syphilis, and tuberculosis. Then post-vaccine associated following rabies vaccination. And recently, there has been reports following some COVID vaccination also. Systemic autoimmune diseases such as SLE, Sjogren syndrome, sarcoidosis, antiphospholipid antibody syndrome, multiple sclerosis, paraneoplastic syndromes, then NMO and NMO spectrum disorders, MOG antibody associated transverse myelitis. Longitudinally extensive transverse myelitis refers to transverse myelitis extending beyond 3 or more spinal segments. LETM causes include inflammatory, which is neuromyelitis optica associated, Sjogren's disease, SLE, Behçet's, CNS vasculitis, infectious causes such as HIV, syphilis, HTLV, CMV, HSV, and varicella zoster, metabolic causes such as copper and vitamin B12 deficiency, vascular, radiation myelopathy. These are some paraneoplastic syndromes. Here our case was encephalomyelitis. So antibodies associated include anti-CRMP5 antibody associated with malignancies such as small cell lung cancer and breast carcinoma, and anti-HU antibody associated with small cell lung cancer, neuroendocrine tumors, and retinoblastoma. These are some case reports of longitudinally extensive transverse myelitis done in Northwest India, and most of the causes were multiple sclerosis, post-infectious, subacute combined degeneration, tuberculosis, meningitis, SLE. This is another study from Eastern India. Here all the causes were NMO, post-infectious myelitis, tuberculous myelitis, and some idiopathic. This is another report of a MOG encephalomyelitis, which presented with optic neuritis, myelitis brainstem lesion, and LETM as a first clinical presentation. Then another report of LETM in Japanese encephalitis with an unexpected complication. Here the patient presented with fever and altered sensorium, and later serum and CSF samples were positive for IgM against Japanese encephalitis. In neuroleptospirosis can also have such a presentation of acute disseminated encephalomyelitis, transverse myelitis. Then there is another case report of post-dengue associated acute disseminated encephalomyelitis. Another case report of LETM in mets of small cell lung carcinoma. And longitudinally extended transverse myelitis due to toxoplasma. The another association associated with brain tuberculomas. Post-COVID-19 longitudinally extending transverse myelitis. Then following vaccination against COVID-19. These are some of our references.
Let me be very frank about this case. Actually, we don't know what's the cause. Nevertheless, why we presented this case is that because I'm sure that in the practice of so many of the senior physicians here, you would have seen cases like this where we would extensively evaluate, and you can see that this patient was extensively evaluated considering that he is an young patient. The neurologist was involved, many other specialties were involved. You can forget about the second, third and fourth diagnosis, that aspiration pneumonia, renal failure or complications of the primary problem. The primary problem was a transverse myelitis and encephalomyelitis, for which we don't know the cause, to be very frank. But the treatment also, you can see all the possible causes we treated because he is an young patient. Nevertheless, we lost the patient. Still, we thought we would present this case just to show that the atypical presentation, what all workup we can do in such a case, but sometimes we reach nowhere. So it was extensively discussed in our clinical club. If you have any thoughts about this, any suggestions, you are welcome to share. So with that, we come to the end of our 3 cases. I hope it was useful for you. If there are any questions or discussions, please.
We had given acyclovir.
Yes, acyclovir. We had given either penicillin.
CSF studies?
Yes, CSF study was also.
Viral panel was done?
Yes, which one?
Viral?
Yes.
CSF viral panel was done?
The viral panel was not. We have given acyclovir. It was evaluated for tuberculosis. He actually comes from Bihar, northeast. We don't know whether it's something related to that area. We don't. No, it is actually not Guillain-Barré. There's a definite level, sensory level. It is not Guillain-Barré.
Because a young patient.
I know, but Guillain-Barré is not like this. He has got a different sensory level. No, it was mute actually. Yes, it was actually a rapid onset. He had a history of fever also. No, initially it started in the right upper limb. Right upper limb. It was not the typical Guillain-Barré we see. It was not. Yeah, that is what is one of our differential diagnosis. No, clinically we can only call it. Yeah, clinically we can only call it transverse myelitis. Clinically with encephalomyelitis, that is a clinical. But what is the reason for that? We don't.
Because you are given everything possible. You are given high dose of steroids. You are given IVIG.
All was that was given, but no response.
Yeah. But how was leptospirosis treated in this case? Only doxycycline, or you gave some other antibiotics also?
Ceftriaxone.
Yeah, ceftriaxone.
Ceftriaxone,
But
yeah.
leptospirosis.
Borderline.
Unlike, of course, because you showed
Yeah. That because we evaluate for that.
case report. Was the patient given COVID vaccine before this, by any chance?
That history part. We don't know that history.
No idea. Okay.
There are no more questions.
There is no question, but excellent cases, excellent workup, and excellent presentations. Congrats to the students as well as to the teachers, and more than that, excellent review of literature. The only question what I want to ask is, how can you work up these cases with these Bihari patients and all? Is there any support? Or
No, actually, we have something called teaching free. Teaching free scheme is there. For poor patients and all, we give concession. That is for each unit, so many cases are allotted. And right now, it is 6 cases, cases per unit. But even there is a limit. In some cases, we approach the management.
without the support of management, this much of extensive workup will not be possible.
I know.
But for a postgraduate institution, this is absolutely essential. Excellent workup. Once again, congratulations.
Okay, thanks.
I thank all these 3 students for the nice presentations. I also thank Dr. Ittyachen and Dr. Koshi for chairing the session. I'd like to invite Dr. Joyson to the stage to give mementos to the students. Ancy Peter. Dr. Ancy Peter. Dr. Anju Sajeev. Dr. Nanditha. Thank you. I'd like to invite Dr. Radhakrishnan to give a moment to the Dr. Ittyachen. I'd like to invite Dr. Rajendran to give a moment to Dr. Koshi.